Okay, so the second case involves a 65 years old male with complaints of gradual progressive diminution of vision in both the eyes since 3 years. His best corrected visual acuity in the right eye is 6/9 parts and in the left eye is 3/60, which improves to 6/60 with pinhole. His intraocular pressure levels are normal within the both eyes, and he also has a history of multiple intravitreal anti-VEGF injections in the past in both eyes and two dexamethasone implants in the left eye over the duration of 2 years. So this is the optos imaging, which shows that the patient has some CSME. And if we notice, then in this part, we can see the old dexamethasone implant, which was already put there in the last visit. And the fundus image shows that there was moderate NPDR changes with a lot of CSME in his right eye. And even the other eye also has similar kind of appearance. So these are the OCT angiography images, which show that there are some flow void areas in the macula, because of which there's a drastic drop in his vision. And on the montage imaging of the OCT angiography, we can see that the FSZ has gone irregular and has increased in size. And there are many capillary dropout areas, which are again a hallmark for his drop in vision because of the macular involvement. These are the OCT images, which shows that there is a large intracystic macular edema with some fibrinoid matter which is within the retina. And there are many hyperreflective dots which are suggestive of hard exudates, though not involving the fovea, but in the perifoveal area. In the change analysis, we can again see that he has a tendency of showing macular edema over the past. And again, there's a waxing and waning pattern where till the time the effect of the drug is there, the swelling subsides. But as soon as the effect goes off, the swelling comes back again. So today the patient is planned for a left eye intravitreal dexamethasone implant under topical anesthesia with a dose of 0.7 milligram implant. So now I'll be switching back to Dr. Saurabh Luthra so that he can proceed with the injection process.
So we have a patient who has chronic CSME with CME secondary to moderate NPDR. And as we saw that in the left eye, there is significant macular ischemia with the flow void areas on OCTA involving the FAZ. And that is why the vision is down. In this case, you can see hyperreflective dots, and the ellipsoid zone is kind of wiped out, and those are changes of chronic macular edema. And the patient is going to get an ozurdex implant in the left eye. I will now show you how the implant has to be handled. So we have to make sure that it is being done from the correct side. It is usually marked on the side on the front of the implant, that you have to open it from the other side. Usually the side is marked. Yes. So we peel it from the side which is towards the handle, not towards the needle, as you will just see. So as he exposes the implant, I just take it out, and you can see it in my hand. And now I'll show you this implant. So this has a protective plastic thing which is extruding out. It just prevents accidental injection. So we have to take this out. Now the implant is armed, and it has some serrated like markings which actually help me to get a good grip on the implant. So like this is the implant grip. Okay, so like this, and this is the button which I will use to inject the implant. So initially I will just do the same sterile procedure as to wash off the betadine which my assistant had used on the lid margin. So is my microscope feed visible?
Yes. Yes.
आप ऐसे रहेंगे सर, बस। इधर ऊपर देखिए, सिर नहीं हिलाना है, आंख से अपना जिस तरफ मैं आपको टच कर रहा हूँ इस तरफ ऊपर देखिए, इस तरफ इधर राइट साइड और ऊपर आंख हिलाइए, आंख। हाँ, अब राइट आई को भी खोल लीजिए ड्रेप के नीचे और इधर ऊपर देखिए, लाइट में नहीं देखना, ऊपर देखना अपने सिर की तरफ। हाँ ऐसे, वेरी गुड वेरी गुड, बस ऐसे ही देखते रहेंगे, बिल्कुल ऐसे ही देखते रहना है आपने। यस, so I will mark 3.5 millimeter in this case because it's a phakic eye. And now I will just gradually displace the punch so that I'm kind of, I don't have the sclerotomy and the conjunctival opening above one above the other. And then I will gently introduce the implant inside. And I will free my right hand now and use it to stabilize the implant handle. And what I'm going to do now is try to, press the handle on the scleral surface so that I can see the tip of the implant inside, the needle inside. थोड़ा सा इस लाइन डालो कॉर्निया पे। So there I can see, just barely see the implant needle tip. Now I will gently start injecting. So if you saw that the implant came out, not as slow or as smooth as I would have wanted it to, but still it came out and I heard an audible click, which is actually, I tell my assistants that you all have heard this audible click. It is important just to make sure that the needle has totally extruded out, and you can see that the tip of the needle here, I mean there is a shaft inside which has pushed the implant in and it has gone all the way to the tip of the needle. So that is the area of the injection, and this is a little, it's not 30 gauge, it's about 27 gauge, so it's a little wider, the entrance wound, and we have to be little more diligent in cleaning that area and also preventing vitreous kind of extrusion from that area. So in the cases of this ozurdex, we will just now put antibiotic. And you can see that the entry and the exit was fairly smooth, and there is no major wound or bleed in the eye. Now we'll just patch the eye. So any questions regarding the ozurdex implant?
Yeah, Dr. Saurabh. Hello, Dr. Saurabh. Fantastic. I think intravitreal seems to be a very simple thing, but you've done it so nicely. And that is what I was discussing with Dr. Ajay Arora. He says, what is so big about it? I said, well done surgery is a well done surgery. So I wanted a comment from Dr. Ajay Arora. He's just joined.
Hi, Dr. Ajay. How are you?
How are you?
Nice to see you there.
No, no, I just landed and I saw Saurabh doing the ozurdex injection. So I think fantastic. I think there are two take-home points for the audience. One, ozurdex should be given in the infratemporal quadrant. It is not given in the, as you gave it, because it should not be given in superior quadrant so that it doesn't come in the visual axis. Second, I follow the same thing, and it works pretty well. It's a very safe way. One small difference I do is that I hold the eye with a caliper, so the eye has no movement at all. So my right hand is holding the eye, and the left hand is injecting. Or my left hand is holding, and the right hand is injecting. Either way, and it works extremely very well. So fantastic, Saurabh, congratulations. And I saw your case. It was a patient with a cystoid macular edema. It's a perfect and had lipid very close to the fovea. So that is a perfect indication for ozurdex. So that's just a small thing. Wonderful, sir.
Thank you, Dr. Ajay. And as you pointed out, infratemporal area is the preferred location. Also, another thing is, since this is under topical anesthesia, patient, even if it bells, the eye move upwards, you will not get, your needle will not get caught. And I think that was a useful tip. You said that we can use the calipers to stabilize the globe while injecting. And why I use, the cotton tipped applicator is I like to, displace the pons from the area of entry so that they don't lie over each other, and, there is no direct access of the external fornix contents into the vitreous cavity. So that is why I prefer to, displace the pons as well.
Yeah, that works perfectly. And what you can do, you can have a bud dipped in paracaine, put it there for a little while. We started off years back, we used to give a subconjunctival injection locally, but then we stopped doing that. We just put a bud dipped in paracaine for a while, and then we inject, so the patient is very positive.
Right. So that works very well in our hands also. And in fact, my assistant had already done that, so I think it works very well, Dr. Ajay.
Great, Saurabh. I'll hand over the mic to Dr. Malay, and congratulations.
Thank you, Dr. Ajay.
So, Dr. Luthra, I think this session has been fantastic. Both of you have done very great work. और सर इसमें सबसे खास बात यह है कि you are speaking from a different state, almost 700 kilometers, and we, I think, have never realized that. So great coverage from your side. There were initial few hiccups here, but I think overall the session has gone very well. Dr. Gaurav, any comments about it? Mike.
Everybody else, we managed to meet everybody else sitting so remotely, and I think this experiment of, as you said, of a live surgery of this kind has been successful, and I'm very happy we can do it in a much better and a bigger way down the line sometime. And I really want to thank all the Kanpur Ophthalmic Society and all the delegates and all the seniors there for bearing, for watching the webcast from our hospital. Thank you.
Surely, yes, we will definitely go ahead and do it. And Mike, hand over to Dr. Ruchika.
Thank you, Dr.
Thank you. Thank you, Dr. Saurabh, Dr. Gaurav, for this wonderful video live surgeries. And I think we also need a big round of applause for them so that they can also hear us, the audience sitting here. Thank you, sir. Thank you. So with this, we come to the end of this wonderful live surgery session, which was like a first of its